Good afternoon, good evening, and good morning, wherever you're dialing in from. Welcome, everyone, and thank you for joining this Cook Medical's OH&S Endoscopic Tympanic Membrane Closure webinar. Today, we're going to be looking at the minimally invasive techniques using the Biodesign Autologic Repair Graft. I'm Miles Williams, and I'm Cook Medical's Otolaryngology Head and Neck Surgery European Training Manager, and I will be moderating today's session. We are very pleased to have had such a fantastic response to this webinar, with representation from 25 nations from around the globe. Today, we have two fantastic speakers who are going to discuss their experience of endoscopic tympanic membrane closure with the Biodesign Autologic Repair Graft. We have Mr. Attila Dezo, consultant otologist ENT surgeon, who has a strong interest in endoscopic ear surgery. Attila works at the Manor Hospital and the Queen Elizabeth Hospital in Birmingham in the UK. Joining Attila, we have Mr. Martin de Wolf, consultant otologist ENT surgeon. Martin works at the Amsterdam UMC at the AMC hospital site in Amsterdam. Martin also has a keen interest in endoscopic ear surgery, having published numerous clinical papers. We would like this to be an interactive event, so I wanted to cover some ways for you to interact with us. Firstly, we're going to be asking a couple of polling questions. This will help our presenters understand some of the ways the audience members may already be performing tympanic membrane perforation closure. You will see these polling questions appear in the top right of your screen. Just to make you aware, you may have to come out of the full screen mode in order to view the bar graph, the icon which is the bar graph. As well as the polls, we will have the question and answer function available for you to ask questions to Attila or to Martin. Please don't wait until the end to post your questions, as there is a delay for us in seeing them. So we want to answer your questions as they come in and when it makes sense to do so. With that, let's welcome our two speakers, Mr. Attila Dezo and Mr. Martin de Wolf. Hi, Attila. Hi, Martin.
Hi. Hi, Miles. Thank you for the kind introduction.
Thank you for joining us. Pleasure to have you both here. So,
without further ado,
and thanks for joining. And to kick things off, Martin, I'm going to hand straight over to you, really to introduce the Biodesign Autologic Repair Graft. So, thank you, Martin.
Thank you, Miles. Thank you, everybody, for joining in from all over the globe. This is marvelous. So, I was asked to say a few words on the background of biodesign. As this is not actually my area of expertise, as I haven't studied it thoroughly, but Cook was kind enough to send me some information and provided these slides. What I do understand from it is that it's a natural extracellular matrix derived from porcine small intestinal submucosa. So this material is decellularized and it leaves a matrix of molecules such as collagen, glycans, and it actually works as a scaffold for vascularized tissue to grow into, so the host cells can grow into this graft. So it's manufactured by Cook Biotech, and it's therefore a consistent US source of healthy animals with the same background, age and weight, and it has a natural strength to it. As we zoom into this tissue, you can see it has a three-dimensional structure. I believe it's 4 layers in which the host cells can grow into, supporting blood supply and regrowth of blood vessels. So as you can see in post-operative photos shown here, which are shot by Mr. Panetti from Italy, and you can actually see on the left side that the Biodesign graft is placed, and in like 2 or 1 or 2 days, you can see the actual ingrowth of vascularized tissue, and in the few weeks following, you can actually see tissue in the new eardrum growing into the scaffold. And in about 2 months' time, you can actually see a quiet ear with a translucent, sometimes even, eardrum. So why do I use biodesign? Well, I came across biodesign during my fellowship in the UK 7 years ago, which is also the starting point for me to start doing endoscopic ear surgery. So what I noticed during surgery there is that it's an ideal graft for particularly one-handed surgery, because you need to use it when it's, or you can use it when it's wet, and when it's wet, it slides easily, and it keeps its shape. It doesn't crumble, and therefore you can easily manipulate it with one hand. So it grips well because of its adequate thickness. And as I use the 2 by 3 centimeters graft, I have abundant material to design the flap or the graft in any way I like it. Next to that, particularly in endoscopic ear surgery, there is no donor site morbidity necessary. And with endoscopic ear surgery, you operate through the ear canal, so there's no need for an extra incision. And what I also noticed that over time, the flexibility of the tympanic membrane is still there, and despite of other grafts you might use. And surely there are alternatives like cartilage, pericardium, or fascia. But there are a few points I wanted to make. Is that, at least it's my opinion. So honestly, I love cartilage. I love to use cartilage. But particularly for the smaller perforations, where you can design a butterfly graft or a diabolo graft and just pop it in the perforation, just like a grommet, for instance. But for larger perforation, I find it a bit too rigid. You can't really manipulate it sometimes in the shape that you really want it to. So that's where you go to perichondrium or pericardium or fascia. But the downside to that, I feel, is that it crumbles more easily when it's wet. And if you place it in situ, you need to dry it first. And that's a bit difficult to do with to place it correctly with a one-handed surgery. So these were the points that I wanted to make out for now, Miles. Are there any questions already?
Thank you for that. We don't have anything coming in at the moment, but please do, as a reminder, you will see the question function with the question mark in the tab there. So please do, if there are questions, please do post them as they come in. We will pass them to Martin and to Attila. So thank you, Martin. I'll now pass over to Attila to talk to us about his case and also his patient selection criteria for using biodesign. So across to you, Attila. Thank you.
Thank you very much. I don't see my slides. Oh, yeah, thank you. Similar to Martin, I came across with biodesign as a product on an endoscopic ear surgery course in 2014. It may have been the same time when Martin was on a fellowship in the UK. And I was immediately hooked by the elegance of the product, and it's off the shelf, readily available, and it's comes in large quantities, large surface area, and it can be inserted without any extra incision. And in my practice, everybody who has a middle ear or mastoid surgery is a potential biodesign candidate. Obviously, because the product is derived from pork, according to the UK General Medical Council requirements, it has to be discussed with the patient prior to surgery as a part of a consenting process. The most attractive side of the product is the endoscopic use, because no extra incision is needed for harvesting fascia or cartilage. And mostly I use it for myringoplasty, tympanoplasty procedures, or mastoid surgery when the cholesteatoma is relatively limited, doesn't go beyond the aditus and the aditus ad antrum. But prior to the surgery, the product is discussed with the patient, and it's all documented in the case notes. Yes, so myelingoplasty is the most commonly used procedure. Endoscopic cholesteatoma surgery with limitations, and combine approach tympanoplasty with obliteration. I also used it a few occasions for revising open cavity mastoid surgery for lining the mastoid process. The ideal candidates for endoscopic tympanoplasty with biodesign graft are dry perforations and primary cases. In a primary case, the blood supply is not compromised when the tympanomeatal flap is raised, and the vascularization is ideal to grow into the biodesign collagen matrix. I don't tend to use it in discharging ears, and if biodesign graft failed in the past, I don't tend to use it second time. I use either fascia or cartilage or the combination of the two. Obviously, it's all determined by the patient's anatomy, the patient's preference. Religious considerations have to be discussed as well. In my part of the world, there is a large sorry, someone advanced my slices. There's a large Muslim population, and also Jewish patients have to understand this product doesn't contain cells. It is just a collagen matrix derived from pork. One of the other limiting factors is the anatomy and the diameter of the ear canal. Cook Medical kindly provided us some supporting information to have the consenting process. So this is a document from the Muslim Council, and the other one is from an article discussing the Jewish perspective to have the consenting process. Thank you very much.
Thank you. Thank you, Attila. And actually, we have our first questions come in, and quite timely, actually, Attila. And also, Martin, you may want to comment on this as well. You've talked a lot. I mean, the question is, what is your advice on counselling patients with religious or dietary objections to biodesign? And I think, Attila, you've covered off obviously the religious beliefs, but have you had any patients who have thoughts around in terms of their dietary beliefs or thoughts?
Yes, it's an interesting question. I think if it's emphasized, the product doesn't contain cells. It's not like eating pork. It is just the collagen matrix is not exactly the same as having cells in the product. I think if it's fully understood and explained in details, most patients would accept it. But you know, if either dietary considerations or religious beliefs can be taken to various degree, and if there's any resistance, I never put pressure on the patient just because I would prefer to use biodesign and they would be a good surgical candidate. But I think the key is to emphasize that there are no cells in the product. It's just the collagen matrix.
Martin, would you have anything to add to that from Attila?
No, I agree. Honestly, as I said earlier, there are alternatives. So it is not. You can use something else if there is resistance to the product.
in a follow-up question to that actually is, do you consent patients similarly for the use of gel foam? Obviously, gel foam being a porcine-derived product, where and this is coming directly from the question. This surgeon is saying they never know where to draw the line in consent.
Yeah, it's a valid point. Gel foam has been used much earlier than biodesign, and for some reason, when during my training, I was never asked to discuss this with the patients, but it's a perfectly valid question. I think it would be equally discussed, and similar to prosthetic products like titanium implants or potentially stainless steel implants. So patients have to know what's implanted into their body, and the gel foam can break down and disappear after a few weeks or months. That is also an important aspect of the same question. But yes, I think it should be discussed.
And Martin, would you agree with that, or where would you draw the line?
Well, I'm not sure legally wise where to draw the line, but in sense of emotion, I can understand that a patient has a bit more of an objection, but towards biodesign as it integrates in the body, although they're not cells, versus gel foam being a resorbable product within a few weeks' time. So I've never discussed this honestly with a patient before, and I'm not sure if you really need to. But it's just my opinion. I've never researched it in depth.
No, thank you. Thank you for the answers, and thank you for the questions. Keep the questions coming in. So before we pass across actually to our Cook headquarters, I just want to remind you that the polls are still open. So we'll be reviewing those shortly. So please do, if you haven't already, please do answer the polls. But I'm now going to pass over to my colleague Alex, who is in the Cook studio. So across to you, Alex.
All right. Thanks, Miles. My name is Alex Brethauer, product manager for Cook's otolaryngology head and neck surgery business. And I'm here in our Bloomington, Indiana headquarters to tell you a little bit about our Biodesign Otologic Repair Graft. As was mentioned previously, Biodesign is extracellular matrix derived from small intestinal submucosa, and it acts as a scaffold for cells to infiltrate and remodel into natural tissue. We have 4 different configurations of our Biodesign Otologic Repair Graft. We have a 2.5 by 2.5 centimeter square sheet. We have a 5 by 5 centimeter square sheet. And we also have 2 configurations with a pair of pre-cut discs. One that has a 4 millimeter and 6 millimeter diameter disc, and then one that has a 6 millimeter and 9 millimeter diameter disc. These disc options are new to Europe and now have really a global footprint. This is also just an example of the material when hydrated so that you can see how it behaves, and it really makes it very easy to work with. So we hope you enjoy the Biodesign Otologic Repair Graft. We'd love to hear from you. If you have any questions or feedback, please don't hesitate to reach out to us or your local representative, and we look forward to hearing from you soon.
Thank you, Alex. Thank you for that demonstration. So next up, I'm going to pass back across to Amsterdam and Martin, who's going to present his techniques when using the Biodesign Otologic Repair Graft for tympanic membrane closure.
Hi guys. So
Over to you,
yes,
Martin.
I'd like to discuss. Thank you. I'd like to discuss with you your surgical options in tympanic membrane closure techniques, and I'd like to share you some of my experience in terms of video. So surgical planning for laryngoplasties. So these are like a few examples of what you can encounter in outpatient clinics. So for those smaller perforations, or for any perforation, you have certain options. So you could either go transmeatally or retroauricularly. You can use a microscope or an endoscope. You could do surgery through the perforation, and as discussed, there are numerous options of grafting material. So I'd like to go over these 4 cases in what I would prefer to do. So for those smaller perforations, I would use an endoscope, and as I said previously, particularly when it's a centered perforation, I would like to use cartilage, which I would redesign into a diabolo or a butterfly graft. But if it's more laterally to the eardrum, to the annulus, for instance, I tend to use biodesign with a small tag on it. So when the perforation is a bit larger, I would have a very low threshold to do a tympanomeatal flap. I would do it transmeatally, endoscopically, of course, and with biodesign. So the TM flap, just to get access to as much bony annulus for the graft to lay onto. And really, this is the same basic techniques for the larger perforations also, except for that I need a larger graft. And I would like to expose as much bony annulus. And there are a few techniques for the latter 2 situations which I want to go into more thoroughly. So if you zoom into case number 3, there is this anterior inferior extended perforation. So what I would typically do is I would infiltrate locally with lidocaine adrenaline 1 in 200,000 or 1 in 80,000. So this has 2 aims really. One is hydrodissection, the other one is hemostasis. The second step would be to revitalize the eardrum, which is mandatory for tissue regrowth, make a wound so that it will heal again. And then the next step would be to open up the middle ear via a tympanomeatal flap. And what I always keep in mind is the fold line, which you can see here with the, represented by the dotted line, is where the actual tympanomeatal flap will flap forward and stick to the anterior wall. And this line runs over the malleus handle. So if you design your Rosen incision, I typically do it inferiorly more medially and cranially more laterally, so that you have an abundant tissue flap which sticks to the anterior wall. There is also another option, which I call a type B incision, in where I extend the incision cranially more anteriorly. This has 2 advantages. One is that it gives you access to the attic for instance, cholesteatoma surgery, but it also gives you access to the anterior superior quadrant of your eardrum to make a anterior superior tag, for instance, which I can show you later on. So after that, you need to actually open the middle ear by lifting the annulus. So that's the yellow line presented here. And what I always keep in mind is that I'd like to extend that incision as far anteriorly as possible, so even far beyond the dotted line, so that it lifts easily, but also you have some extra bony annulus which you can rest your graft on. Then redesign the grafts to cover as much bony annulus as possible, and after that flip it all forward and putting sponsorstand in the middle ear to give it some extra lift. So this is the typical case where I place some local in there. You can see the nice whiteout from the hydrodissection and hemostasis, and then revitalizing the eardrum. I use a Rosen needle here, And I keep in mind that I also need to dissect the inner lining of the ear, of the middle ear, so it's for easy access. And then I take out the abundant tissue, and I have a nice wound for postoperative healing. Then a Rosen incision with a Rosen knife, so inferiorly close to the drum, and more cranially and more lateral placed in the ear canal. Then I use a cotton wool ball soaked in adrenaline. This is willow spoon, which is resorbable, but you can also use a neuropathy or some sort. So then lifting the annulus, extending anteriorly, and then a little bit further, and then for the final bit, I change back to the Rosen incision, Rosen knife, to extend it as far as I can. As you can see with endoscopic ear surgery, you have a nice overview of this particular area, which is normally pretty difficult to see with a microscope. So this is the Biodesign graft. As you notice, it just lays flat, and it just spreads out. It doesn't crumble up. So I position it, and then I place it underneath the eardrum, stick it anteriorly, and then next step will be to check the ossicles and to fill the middle ear with Spongistan or gel foam or whatever you have available. And I would take particularly notice to do it in the anterior portion of the eardrum, but you can also place it a little posteriorly. So filling it all up, you can't do it too much really, because, well, there's always some extra lift from behind. It doesn't hurt anyone. So positioning the graft again, flipping back the tympanic membrane, flap, and then checking whether or not the graft is nicely smoothly placed. And then I just pack the ear again with gel foam, Spongistan, and I do it with a few pieces, and then I would hydrate it with a antibiotic eardrop to make it a pressure dressing, really. So that's the first case. And the other one, the subtotal perforation, you can see here, there are a few options I think you have. Is on the left side, you see anterior tag technique, where you have your, as I said, A-type incision with an extra incision in the anterior part of the ear canal wall. And then you have the superior tag technique, where you have the extended incision. For the graft design, something similar to this. Basically to cover as much bony annulus as possible. So I'd like to show that to you in a video. So this is the first case with the anterior tag. We go fast forward into opening the middle ear, revitalizing the perforation, the tympanomeatal flap, actually lifting the annulus towards here, and opening up as far as anterior as possible. And then I, well, sometimes measure the perforation size, design my flap. What you can see here in the tip of the instrument is the anterior tag, which is relatively small. I usually make it a bit larger, about 2-3 millimeters in length and 1 to 2 millimeters in width, because it makes it a lot easier to pick it up through the extra incision you make. So then, for some extra lift, I fill the middle ear and make sure that it's a nice and smooth surface. This is the post-operative image 2-3 months later. The next and last video, I'd like to show you the anterior superior tag technique. This is where we're aiming at. So you have a tag that comes from the middle ear, and you can just place it over the anterior portion of the scutum, and then there is the posterior portion of the graft also. So this is mid-surgery, where I open up the middle ear from cranially. I lifted part of the eardrum from the malleus handle, and here you can actually look into the eustachian tube. So the design of the graft is like oval shaped or rectangular shaped with an incision from the top. This incision makes it possible for the graft to wrap around the tensor tympani. So you can place Biodesign into the middle ear, and as you know, it doesn't crumble up. It just likes to keep its shape. So therefore, it's pretty easy malleable, particularly from behind, and then you can have a look through the isthmus in the anterior portion, reposition your graft, and then with a suction or a forceps or a hook, you can pick it up and just pull it through the small perforation there, and then just lay it on top of the scutum here. So, and then you can just slide it out nicely. You can also, with the endoscope, have check if the actual skin is covering the graft in the edges, and then you can flip it all back and flip the tympanic membrane back in its place. And then I always fill up the middle ear again with Spongestan to give it that extra support. But I'm not relying on that support solely. So I always try to place as much, to cover as much bony annulus as possible. So filling it all up and closing the actual drum, the graft and the drum itself. And this is, I always like to check if it's a nice, smooth surface for the eardrum to grow back onto. So a few take-home messages, tips for 100 endoscopic tympanoplasties. Please make your tympanomeatal flap as large as possible so that it sticks anteriorly. It makes your life a whole lot easier. Extend the incision as far anteriorly as possible to make it stick anteriorly, but also to have as much bony annulus available. And if you use an anterior tag, make it relatively long so that it's easier to pick it out of the middle ear. In terms of Biodesign autological repair graft and one-handed surgery, well, it keeps its shape and it doesn't crumble, and you have no donor side morbidity. Those are the main beneficial points, I think. So this is it for now. Miles, do we have any questions coming in already?
Do actually, please, Martin. Yes, we do. No, thank you for that. I think your images, your videos were fantastic, and I love how you demonstrated the raising of the tympanomeatal flap there. I thought some great graphics. So thank you for that. Just one or a couple of questions for you, Martin. One was somebody didn't catch the name of the resorbable cotton wool that you were using there.
Yeah, it was Willow Cell, which is a Dutch company. But I have to say, I used it back in the day, but they stopped producing it because there was not much ask for it. So I now use actually a cotton ball or a neuropathy. Neuropathy has metal in it, so it's radiopaque. So that's probably the best option.
Okay, great. And also, Martin, and Attila, you can jump in as well. What would you do if there was tympanosclerosis surrounding the perforation? What would your take be there?
Wow.
I don't have a one step forward in this. It's more like if it's in the way for surgery, or when I can't really fold the tympanic membrane forward, then I would take it out. I would not necessarily take it out all the way and always. It's just the way it goes, really. What about you, Attila?
Yes, similar. So tympanosclerosis is not just one condition. It could be a completely rock solid eardrum, and it could be just a thin layer of hard deposits in the eardrum involving one segment of it. So if it's limited to the surface of the drum, I try to work around it, and I would graft it without removal. If it is involves the the whole surface of the drum, and the drum is almost like a rock solid plate, probably I wouldn't use biodesign, and I would use underlay fascia graft.
Okay, thank you. Thank you for that. Before we pass to Attila, I think we'll take this opportunity to look at the first poll question here, and interesting results. So the first question was, what approach do you use for laryngoplasty? And here actually a very even split between endural, transcanal, and post-auricular. A very even split for those answers there. So yeah, I think that is the first poll. And I also just want to cover off, we've got one outstanding question here. Was actually in regard to a question about Cook, and does Cook actually provide a patient consenting pamphlet or leaflet in regard to the use of biodesign autologic repair graft? The answer is we don't, but I believe a lot of hospitals will actually generate their own. I'm not sure, Martin or Attila, if your institutions actually create their own consenting leaflet or pamphlet for repair of tympanic membranes.
We don't have a pre-made printed one. We have information leaflets regarding the procedure and outlining the general and specific risk involving the surgery itself. I think consenting has to be tailor-made to the patient, and the specific aspect of the surgery has to be discussed various degrees depending on the patient's, religion, occupation, or specific questions. I think having a box standard one for everybody is not the best way around it, because the specific either procedure or patient-related details get lost. So I don't believe in a pre-printed one for all consenting process. I'm not sure what's your take on it, Martin.
Well, same here. Honestly, we are mandatory to make a patient-based discussion about the risks and all things involving this surgery. So we don't have any pre-made leaflets either, but we do have an information folder. Yeah.
Great, thank you. So now across to Attila, and Attila, if you could take us through your techniques when using the biodesign autologic repair graft.
Thank you. I used biodesign mostly for endoscopic tympanoplasty and meringoplasty procedures, but not only for those. I also use it for open approaches. But the most commonly for the endoscopic meringoplasty and tympanoplasty procedures. And it can be handy for lining mastoid cavities, and also if there is an accidental perforation during an ossiculoplasty or stapes procedure, it's really, really nice to have a product just off the shelf, taking a small piece out and patch the hole instead of taking a graft material for somewhere else. It was really handy on a few occasions when I had to patch a iatrogenic perforation. Handling is rather easy. I trim it when it's dry and try to shape it depending on the demand of the procedure, and hydrate it before insertion. Insertion, as you already have seen, it's quite straightforward because of the thickness and the persistent consistency of the product, and it's very easy to fold it and push and pull it when it's hydrated, and the consistent thickness 0.4 millimeter is really handy. My typical case is an endoscopic tympanoplasty. In the UK, by tradition, almost every case is under general anesthetic. I prepare my case with Marocel Popvik inserted in the anesthetic room prior to the procedure, and I soak the Marocel Popvik with adrenaline 1 in 10,000. So during the anesthetic process and transferring the patient from the anesthetic room to the table, there is at least 15 minutes. So it's going to give me a good baseline vasoconstriction. And as you have seen it earlier on Martin's video, I also infiltrate the ear canal with 2% lignocaine and 180,000 adrenaline. It's usually not necessary to inject more than one cartridge, sometimes two. And trimming of the ear canal hair it's really important. It's tedious, it's time consuming, and it makes the surgery longer. But it's a good training tool for the junior trainees to get familiar with the endoscope and the hand-eye coordination working from the screen rather than through the microscope. And yes, freshening up the edge of the perforation is an important aspect. I tend to use the Rosen knife, the diameter of the Rosen knife, to size the perforation. So one fold, two fold, three fold, and when I size my Biodesign graft, I make little prints of the Rosen knife on the Biodesign before cutting it. I raised the tympanometer flap with 0-degree endoscope. I guess I used the Biodesign graft only once without raising a flap, and it wasn't a good outcome. And always check the ossicular chain, clean the Biodesign dry, and inserted in an underlay fashion, exposing the tympanic annulus, the bony annulus, as far as you can. It's an important aspect because the blood supply comes from the side, and unless the perforation is really a small one, I use gel foam to support it from the side of the middle ear, and the tympanometal flap is replaced, and I put gel foam on the outside as well. In terms of packing the case, I use Marocel Popvik, and I soak it with ciprofloxacin and dexamethasone containing eardrops, and discharge the patient on the drops. Use it for a couple of times a day for 2 weeks. And my first follow-up is 2 weeks after surgery when the Marocel pack is removed. And if it's a tympanoplasty or a meringoplasty case, I follow the patients up to 12 months. I see them once or twice more with audiometry on arrival. And I'm not in a position to keep them under further follow-up if it's a successful surgery purely for audiometric or long-term follow-up perspective. But if it's cholesteatoma operation, I follow every case up at least to 5 years with diffusion-weighted MRI scan at year 1, year 3, and year 5, and revise if necessary. So these are 3 intraoperative pictures of the use of Biodesign. The first one on the left is an attic defect. The second one is when the flap is raised and the Biodesign is being inserted with a needle. And the third one is when the Biodesign is in place, the defect is closed, and the tympanometer flap is replaced. This is a video about demonstrating the insertion of the Biodesign for a subtotal perforation. It's a relatively large piece of Biodesign graft, gradually inserted, covering all aspects of the perforation. And as you can see, it's easy to progress with the graft. It's rigid enough to push it. It doesn't fold backwards and curves back on its own. And I find it easier to insert it hydrated if it's a large one. So this is the next step of the surgery when the tympanomeatal flap is replaced on top of the biodesign graft. You can see it's a large flap because it was a subtotal perforation. And putting gel foam underneath the biodesign graft is important, especially if we are talking about the large perforation. As you can see, there is a small corner of the graft which folded back. It has to be pushed under the anterior, most superior part of the perforation, and there is plenty of gel foam. You could see the rim of the round window niche for a second, and after plenty of gel foam underneath the biodesign, the graft and the tympanomeatal flap is folded back on the ear canal bone and the tympanic annulus. So this is the final step when you can see the flap and the biodesign graft is in continuity and the subtotal perforation is completely closed. And the gel foam comes on top of this, and the marrow cell pulp wick in the ear canal, either 2 or 3 depending on the diameter of the canal, and soaked with ciprofloxacin drops. And this is photograph showing an 8 months post surgery picture of the fully integrated biodesign graft. Thank you.
Thank you for walking us through your applications there. Just going to come back to our polls now, and we'll review our remaining 2 questions that were in the poll. Both, again, very interesting results, actually. The first, or the second question rather, was what approach do you use for laryngoplasty? Sorry, that's the one we have covered. Apologies. But yeah, the visualization method. What was the visualization method for laryngoplasty, tympanoplasty? And actually, the results that came in here were 40% in favor of using the endoscope. So 40% of our attendees today are using the endoscope. 25% are using the microscope as a standalone for tympanic perforation closure with laryngoplasty, tympanoplasty. And then also both, so interchangeable was actually 35%. So it seems that, yes, endoscope certainly has the majority, but we do also have a good number of microscopic surgeons joining us today as well. And I wonder, Attila and Martin, seeing as we have good attendance of microscopic surgeons on here as well, what can biodesign bring to those microscopic surgeons as well? Yeah, we don't want to exclusively use this with endoscopes. What could these microscopic surgeons pick up from using biodesign?
Well,
I think the advantages are equal. Sorry, Martin, go ahead.
No. Well, it's the same message, I think, because, well, the biodesign has extra advantages with one-handed surgery, but this also counts for two-handed surgery. So therefore, I think all the benefits we share today it goes both ways. It's just an easy product to use. So yeah. Any specific things? I don't really think so. No. What about you, Attila?
I think it can be especially helpful for revision cases when fascia has been harvested often more than once, and it's not readily available, and it's all scarred up. The temporalis fascia has been taken out, twice, and the perichondrium may have been used as well, and also from the practical point of view, it's also a great time saver for a long operation. When you spend 3 hours chasing cholesteatoma, you have a relatively small defect on the eardrum because most of the disease was in the mastoid, and when you are closing and you finish the operation, and it's really the time saver to have something off the shelf, and it's an easier grafting material. So it's not purely for the endoscopic use. It can be used with microscope as well, both for tympanomastoid surgery and cholesteatoma surgery as well.
Yeah.
And the final poll here was actually what graft you typically use for tympanoplasty, and the options were temporalis fascia, tragal cartilage, tragal perichondrium, or the Biodesign autologic repair graft, or other. And actually, the split there was a very even split throughout this. So we have certainly representation from across all these grafting materials, which is great. Okay, so please keep the questions coming in. We do have a couple of questions here to answer, and one will come straight into now to maybe Martin. If you need to trim the graft after you have placed it, are you able to cut it with micro scissors, or do you need to remove it and redesign it?
Good question, honestly. Surely I've had this difficulty where you think, okay, I've placed it, it looks very nice anteriorly, but then there is this portion which is slightly too large, covering the posterior wall of your ear canal, and then it's just not the right shape, and then you have like this dog ear on top of it, and you don't want to take it out. So yes, I've been able to cut it out with a micro scissors, being a straight or a curved one. It doesn't really matter. And you're able to do that with one hand, because the thing with this Biodesign is that, well, it keeps its shape, and it is relatively thick, so it's relatively heavy, and it sticks to the to tissues really when it's wet. So you can't so you can easily trim it without having to have the second hand to hold it, because that's where your endoscope is in. So you're able to do that. And also, if you need to take it out and it's still wet, you can easily trim it again and place it back in, because it keeps it safe. It's not much more difficult than when you trim it when it's dry, honestly. So yeah, you're capable of doing that. Well, it might be a bit more difficult when you're just starting endoscopic ear surgery, honestly. But if I were to do it with a particular graft, it would be this material.
Thank you. And Attila, do you think there is a learning curve to using Biodesign? Do you find there was a learning curve when you started?
I started in 2014. I'm not sure there's a much learning curve with the Biodesign. There's a definite learning curve with the endoscope. The endoscopic surgery, the skill with the endoscope doesn't come overnight. And I found it useful to have a good rhinology training in the past, and I had reasonably good experience with endoscopic nasal work, so they were transferable skills. But the junior surgeons pick up the endoscope very easily because they grew up on video games, and they are much more used to work on screens than my generation. So the junior trainees have an accelerated learning process compared to my age group. But the biodesign itself, I don't think it needs a particularly long a learning curve because of the consistency of the product.
Okay, thank you for that. And in regard to techniques, still as we're coming off the back of our techniques here, any tips from either of you of how to make the biodesign stick to the underside of the tympanic membrane if either of you have performed a push-through laryngoplasty? I don't know if either of you have experience with that, the push-through technique.
I used it once, tried to create there's a group in Boston who has a specific design for a push-through graft, and I tried to use it. It's similar to a butterfly graft, but it failed. I tried to put some gel foam underneath, and it didn't work. I don't have good experience with it. If I raise the tympanometer flap, gel foam underneath the biodesign to support it, to maximize full surface contact with the graft is the best way around it. Martin may have different experience with push-through techniques.
Well, I think my experience is slightly limited also because, well, I tend to use the tympanometer flap, but on occasion I've done it. Well, I think the key thing is to fill the middle ear as much as possible with larger pieces of gel foam, and then through the perforation, and then so much as that it actually bulges out of the perforation again, and then make your take some time to make the size of the graft just right, with a little over like a 2 or 3 millimeter wider than the perforation, and then just push it underneath, first anteriorly and then later on posteriorly, and then hopefully it'll just sticks underneath the drum. I've done it in a case where I wasn't able to do an anterior attack because of the curvature of the ear canal, and I could just barely see the anterior rim of the tympanic membrane. So I decided I could see the perforation, so I decided to just do it this way, and it was successful, honestly. But I agree with Attila. The best way forward is to use a tympanometer flap, honestly.
Super, thank you. Okay, to move us on now, I'm going to come back to Amsterdam and to Martin, who's going to talk us through the post-operative care following use of biodesign autologic repair graft.
Yep. So just a few words and just 2 slides, honestly. So basically, all tympanoplasty. Well, I do all my tympanoplasties with with an endoscope, and therefore surgery is a day case surgery. And the ear pack, as I said earlier, was Spongistan in the middle ear, then the biodesign underneath the tympanic membrane, and then Spongistan on the tympanic membrane again. And this is where I take a few minutes to position it so that it's snugged around the eardrum, and it's filling the entire area just around the eardrum. And after that, I fill it with ciprofloxacin drops, so the biodesign just soaks it up, or the biodesign, not the Spongistan, soaks it up, and it actually becomes a small pressure dressing. So this could be just enough, but I decided to place in another gauze with an antibiotic ointment, because in some cases the operation surgery is traumatizing to the ear canal skin, and I'd like to keep a moist environment for the skin to heal nicely. So that's why I placed the the gauze with the antibiotic ointment, and then I place a 10 by 10 centimeters fatty gauze in the concha, and then I put a band-aid on top. This is what I leave in place for a week, so people go home with this, and then after a week I see them in the outpatient clinic. So I unpack the ear, meaning the fatty gauze and the gauze with antibiotics, and then I try to have a look at the middle ear. So I suck out most of the spongistan, and sometimes I just leave it in place because it's some extra pressure on the eardrum. I then give them drops home to take 2 times a day, and then 2 weeks later I see them again, and then I clean out the entire ear canal and have a look to see the graft and the eardrum. And then if all's okay, there's no extra care needed, and I see them 2 or 3 months later for audiometry and a check on the graft. And then if I'm lucky, and most of the time I am, people come back in a year's time to check hearing and to check if the graft is still there, and then I discharge the patient from my care. Thank you.
Thank you, Martin. Attila, have you got anything else to add? Is that a similar protocol that you adopt?
Very similar protocol. I don't use any external dressing. I use the marrow cell pulp we can soak with ciprofloxacin drops and leave it in place for a couple of weeks. And similar to Martin, follow up to a year if it's tympanoplasty or myringoplasty, and see them once or twice in between the first and the last follow-up, and have an audiometry on the second and the third occasion. Outside dressing, external dressing is usually not necessary.
No.
Super, thank you. Okay, and now Attila, if you could take us through your outcome data, that would be great. Thank you.
Thank you very much. One of our registrars went through the endoscopic series in preparation to the British Academy of Otolaryngology meeting in Birmingham. It's a retrospective case series review going through my own data between January 2016 and October 2019. It went on for 3.5 years, and unfortunately, after COVID, the ongoing data collection stalled because the routine middle ear surgery service was suspended. And the data collection included the patient's demographics, operating details, post-operative outcomes, and first follow-up was, as we discussed, in 2 weeks' time. And it went on for a year. The decision of using the endoscope, it was the discretion of the surgeon, but obviously a patient's preference was considered, and the limitation of the ear canal, the extent of the perforation, and a coexisting middle ear disease, it was also discussed. Together with religious and cultural preferences. And the study period involved 44 months, and 58 patients' case notes were reviewed. The female-male ratio was 28:30, and the mean age was 45 years. On the right side of the slide, you can see the comorbidities. Smoking was the highest group, followed by diabetes, ischemic heart disease, COPD, chronic kidney disease, alcohol consumption, and corticosteroid use. The indication of the surgery was tympanic membrane perforation in 41 cases, and cholesteatoma in 15 cases, and they were the sporadic cases that we used biodesign in glomus tumor on one occasion, and once it was used for reinforcement purposes in patulous eustachian tube when the floppy segment of the eardrum was moving together with breathing, and the patient found it really, really annoying during exercise. This slide summarizes the location of the perforations. The largest group was the posterior perforation, followed by anterior and central perforation, and 5 out of 41 were subtotal. This is the result summarizing the tympanoplasty group, and the mean age was 51 years, 49% male, comorbidities in 29% of the cases, and 87% of the cases were primary surgeries, and the rest was revision. Biodesign was used for majority of the cases on its own, and for 33 cases and 4 cases where biodesign was in combination with pericondium and cartilage. Tympanometer flap was used in 97% of the time. As I mentioned earlier, I used it through a perforation, tried to create a wind graft based on the description of the Boston group. It didn't work in my hand, but it's something we could work on later. I am not dismissive about it. And meningoschlerosis was present at 36% of the time. There was no case with intraoperative infection. They were all dry ears. And mean operating time was 94 minutes. I have to say every case involves training. So it's not just the primary surgeon. We always have 1 or 2 residents sitting with us doing different parts of the surgery, which obviously doesn't make the procedure any quicker. The majority of the cases were discharged on the same day in 90% of the time, and 2 were planned overnight stays because of the age of the patient or comorbidities, and 2 were unplanned overnight stays because of urinary retention and slow recovery from anesthetic. And acute post-op complications, 9, which is a relatively high percentage, 22%. Infection was in 6 cases, excessive pain, taste disturbance, and granular meningitis. On the first follow-up, on average on 16 days, the neotympanum was intact in 90% of the time. And on the cases when it wasn't intact, there was partial perforation which healed up later in 3 cases. And on 1 post-op infection case, we completely lost the graft. The infection was so severe that it looked like no surgery was performed. But it may have happened with any graft. I don't think it was specifically to do with the biodesign graft. The last follow-up in this group was on average at 8 months, and the neotympanum was intact in 80% of the time. There were residual perforation anteriorly in 6 cases, and later we lost another graft. For the failures, 4 had revision surgery, and 2 symptomatic patients were not willing to have any revision case, and 2 asymptomatic residual perforations were happy with the outcome of the procedure. So this slide summarizes the cholesteatoma group of 15. Interestingly, the main age group was much lower, at 30 years, and it was a male predominant, 66.7%. The comorbidities were non-existent in this group, and it was primary surgery 46% of the time. 8 of 15 were purely biodesign grafts, and 2 out of 15 were biodesign and cartilage, and 5 with biodesign cartilage and perichondrium. Tympanometer flap was raised, of course, all cases in the cholesteatoma group. Meringosclerosis was present at 13% of the time. There was no sign of intraoperative infection. They were all dry cases. And not surprisingly, the mean operating time was much longer, 134.9 minutes on average. The discharge rate on the same day was lower, 73% of the time. 3 were planned overnight stay because of the long anesthetic and the late finish on an afternoon list. And there was 1 unplanned overnight stay with chest pain to rule out ischemic episode. The acute complications were similar, around 20%. 1 infection, 1 taste disturbance, and 1 bleed. The results of the cholesteatoma group, the first follow-up was similar to the tympanoplasty group, 16 days. The neotympanum looked intact in all 15 cases. At the time of the last follow-up was 6 months because the study had to be finished. The neotympanum was intact at 86% of the time, and two patients had a residual anterior perforation, and both cases were asymptomatic. And we had 2 cholesteatoma recurrence. Interestingly, they were both behind fully healed neotympanum, and they were spotted on follow-up diffusion-weighted MRI imaging. So overall, in 50, including all 58 cases, on the first follow-up happened on average in day 16. The neotympanum was intact on the first follow-up in 93% of the time, and on a median of the last follow-up, 9.5 months, we had a neotympanum implant in 82% of the time, including the tympanoplasty and the cholesteatoma group. So in conclusion, the endoscopic midway reconstruction with biodesign autologic repair graft is a safe and effective operation. The main advantage of using biodesign graft in combination with endoscopic techniques is a scarless and bandage-free operation with short inpatient stay, and the results are comparable with conventional techniques. But careful patient selection is really, really important. Thank you very much. I'm sure we will have some questions after these.
Thank you, Attila. Indeed, we do. We have a good number of questions here. So we have 15 minutes remaining. So if anybody would like to get their questions in, please do take the opportunity now to submit some more questions. But yes, question here. Martin, perhaps you may like to take this one first, and Attila, if you have anything to add. But how much time is saved using biodesign, the autologic repair graft, instead of harvesting autologous tissue?
I think if I would harvest tissue, it would probably be perichondrium, which I would take from the tragal cartilage, which would take me, I think, and closing up again, like 15 minutes or so. But then you need to redesign it and to clean it out and incise it, versus opening the package and doing all that again. So it will probably be 10-15 minutes or so.
And Attila, anything to add?
It could be easily more. So if you harvest the cartilage from perichondrium from the tragus, it involves another incision and peeling of the perichondrium, either on its own or together with the cartilage. Some surgeons harvest the perichondrium or cartilage from the back surface of the concha. It's an interesting way around it, but it adds at least 15 minutes extra, and also introduces another incision, another comorbidity, another potential cause of infection and scar. So at least 15 minutes extra.
Okay, interesting to know then. So 15 minutes at least. And have either of you, or do you know of anybody who's had issues in obtaining biodesign due to costs? And bear in mind, we have 25 countries represented globally here. All healthcare systems are going to be different, but have either of you had experience of having issues with the procuring of this biodesign autologic repair graft?
I didn't. I was lucky enough to find it on the shelf already when I started. When I learned about this product on a course, I went back and used after the course, and I started talking about it with my colleagues. And one of our scrub nerds said, "Oh yes, it's on the shelf. The surgeons use it for hernia repair." So all I had to do, I just had to, because it was already in the procurement process, all I had to do, we just had to order a different size. And no one asked me to go to the approval process to start with, but it was just pure luck. And I haven't heard anybody who was struggling to have fundings for it, but I can imagine there are certain countries and healthcare systems when it's going to be an issue.
And Attila, if I could just mention there, of course, that was you mentioned the biodesign hernia grafts. Obviously, biodesign is a platform technology, and it is the autologic repair graft that we're using here for the tympanic membrane closure. But I accept what you're saying, and I think it does make it easier if the biodesign family is already into a hospital system. It's a new then application and not necessarily a new product having to be placed on the system.
Yes, thank you. Yeah, thank you. Of course, it wasn't the same thickness and wasn't the same as exactly the same product, but it was the same product family, same company, and the same procurement process. So I was lucky enough it was a simplified process obtaining it. I'm not sure how you started using it, Martin.
Well, I believe I was the one introducing it to at least my hospital, but I think also the country. It may already have been in the hospital, because I haven't had much trouble introducing it in this hospital. I had a chat with my direct colleagues, and they were using alternative products. And there was a slight discussion on price, honestly, but biodesign wasn't, well, the same price range and maybe even a bit cheaper compared to human tissue. And therefore there was not much of a problem introducing it in this hospital. And then during the years, biodesign stayed, and the other alternatives, they were taken off market. So we now have biodesign, which we're happy with.
And from the question that comes in, it could be that somebody is struggling to get biodesign into their hospital. Do you have three takeaway tips perhaps for them to argue and to gain biodesign perhaps onto their shelf and help them with that?
I think talking to other surgical specialties who may use it, I think that's useful. It was useful definitely in my case. And if a business plan has to be outlined, I think putting emphasis on day case use to save money, and also reducing surgical time to save money on theater usage time. These two arguments would look really nice on a business plan.
Yeah. Yeah, I agree. There's not much there's not much I can add to that, honestly.
And another question here: if a patient refuses the use of gel foam or indeed Biodesign, is there an alternative to using gel foam or gelatine sponge in the middle ear space?
I haven't come across with this before, because gel foam I don't specifically discuss. Maybe I should. Maybe something I should change in the future. But I think middle ear surgery can be performed without use of gel foam, or without leaving gel foam in the ear, even if it's used during the procedure. Yes, for grafting, the gold standard has been for decades temporalis fascia, cartilage, and a perichondrium, and that one is always available. And pericranium can be used if fascia or perichondrium is not available. So in terms of grafting, there is always something to rely on. And in terms of securing the graft and finishing the operation, I think gel foam is not essential, but it's a good supportive material.
Yeah, I agree.
Martin?
Yeah, I agree. Particularly if you use a technique where you have as much bony covering of the graft covering the bony annulus, you have upward lifting, and then Biodesign of gel foam is just an additive to that. Same goes for the interior tag technique, where you just hang your graft in the middle ear. Then you might be able to. I think you have a fair chance of closing the eardrum without the use of putting something in the middle ear. I don't know any product that has not got any animal substitute surrogate in it, so I'm not sure. And I agree with Attila on the alternative grafting materials.
I think some people use marrow gel to fill up the middle ear, but I'm not sure what's in marrow gel. That may be an alternative, but it may also be another animal product.
And with the Biodesign, once the Biodesign autologic repair graft has been placed, if there is a gap once it has been placed, are you able to palisade it to cover defects?
If I understand the question correctly, yes, it can be used in a palisaded fashion, similar to pieces of cartilage. Yes, I use them a few occasions, overlapping pieces to bridge a bigger defect. Yes, so in short, the answer is yes. I'm not sure, Martin,
Yeah, I may have
what's your
done that
experience?
one. I think I may have done it once or twice. Yes. Yeah.
Okay, well, we've got one more question here. And what does the graft look like during the healing process? You know, if you are in your protocol and your follow-up, what does the actual Biodesign autologic repair graft look like? Is it similar to temporalis fascia or other graft materials? What does it actually look like when you review these patients in clinic?
Well, sometimes I actually see the graft when your tympanomeatal flap is shortened a bit, then you can actually see that the graft laying on bone, really. So for at least a week after surgery, and then I would just pack it and leave it, and then a few weeks later you can just see that there is tissue growing into it. What I also noticed is that a little bit more with biodesign than with other materials is that ear becomes a bit moist. There's a bit of a tissue reaction going on, so there is fluid coming out of your ear, but it's not much of a problem really, because it may look terrible at start, but if you just give it a few weeks, it just dries out, and then you have your neogenesis of vascular tissue. So yes, basically at 1 week I can actually see the difference between biodesign and the tympanic membrane, but after that it just becomes one piece of tissue, really.
Yeah, experience is similar here. I don't see them as early as Martin does, because I take the pack out in 2 weeks. But initially it looks like pink blotting paper, and it's slightly wet. And with time it becomes a homogeneous a neomembrane. And after a few months, you couldn't tell, what graft was used, because it heals the same way as a fascia or perichondrium.
Okay, and we've got just one final question here. I know we're coming up on time, but one last question. Have you ever used biodesign autologic repair graft in the outpatient clinic to simply cover tympanic membrane perforations as an onlay graft? And if so, what outcomes did you get? I'm not sure if either of you have.
I think it's a great idea. It's a great idea. It could be used for diagnostic purposes. For example, if you have a floppy segment for patulous eustachian tube, and you want to predict whether reinforcement tympanoplasty is going to work or not, you could put a tiny piece in the clinic and to check the patient's symptoms. I haven't used it for closing perforation, but I have seen it presented on a conference from the States. It has been used, not necessarily overlay graft only, but it's a combination of over and underlay. Try to flip through the perforation and having a disc underneath and over as well. But in the UK, there is no real opportunity to use it as a office-based procedure due to logistic purposes, but other countries have different take on this. I think it could be used, and probably with good results.
I have no experience, Miles.
I didn't think so, Martin. No, that's fine. Thank you. And just sneak in, just before we close, one last question here. Do you get different success rate for tympanic membrane perforation closure between the adult population and also pediatric cases, or have you had similar results?
I don't think I have enough data to answer this question from the statistical point of view. Pediatric is difficult because of the size of the ear canal, and my waiting list has gone huge during the COVID, especially on the pediatric side. So probably I could answer this question in a year or two, because we use it in the pediatric population as well. Martin, do you operate on children?
Yeah, so I use it in both populations, but honestly, I don't have the data yet, because I haven't looked into it thoroughly yet. It's my feeling that it doesn't really make a difference, but as I said, I haven't looked into it.
Okay, thank you. Thank you for answering that final question. So we're on time. So a big thank you to Attila and Martin for sharing their experience with the Biodesign Autologic Repair Graft. And of course, a big thank you to you for attending and joining us today. We hope you found this session to be informative. But please, if you do have further questions, you can contact us at cookohns@cookmedical.com, or you can visit our website, cookmedical.com. But thank you, everybody, and see you again soon. Bye-bye.
Thank you.